We're at the 7th Conference on Pathogenesis, Treatment, and Prevention in Kuala Lumpur. We're here with Chris Beyrer, who is with the Bloomberg School of Public Health in Johns Hopkins. And we appreciate your time here because you're going to be, in another year, you're going to be the chair of the conference, and you're going to hopefully make a great deal of impact because of the work you've already done and work you intend to do in prevention. So let's start with a little bit about your background, and maybe I think that would be a good place to start with where you're coming from and why you're doing what you're doing. Let's say it that way.
Right. Well, so I'm a medical epidemiologist, and primarily have worked in HIV epidemiology and prevention from the public health population perspective. Which is a little different. Many of the people who've led the IAS in the past really have a clinical care background, and of course our current president, Francois Beyrer, is a basic scientist, and of course one of the co-discoverers of HIV. I think, in epidemics, there's always a role for epidemiologists and for thinking about the epidemic at population levels. So that's been a big focus of my work. And of course, that leads immediately into prevention and the goal of epidemic control, which for many years was not so much a part of our thinking, but of course in the last few years, huge advances in treatment, the understanding that treatment really is prevention, and new advances in prevention and implementation have all led us to a place where we're really starting to think that control of the HIV pandemic may be possible, and is already beginning to be seen in a number of populations. It really is a thrilling moment, but of course there's a lot of work to do.
We've seen the pre-conference presentation, which you were there, on Malaysia, and it seems like they made a great, and then Cambodia, I guess it was Cambodia.
Yes.
So there is efforts in societies where they really make a concerted effort and hit it hard and hit it early.
Yeah.
And I think that's kind of the mantra, but the genie is out of the box, so to speak, because we're down the road. We now have to think about reintroducing ideas that maybe were useful in the past, but maybe have to be reignited and re-energized. So how do we get further down the road of prevention without in a time where people are less worried about scared of the virus? Let's put it that way.
Yeah. Well, I think it's there's a couple of critically important steps. The first thing is that we still, of course, have an enormous number of people living with HIV who are not tested and not treated, and for their own health. For their own well-being and for their own future and the future of their loved ones and families, the goal of treating everybody who needs treatment is still critical. And in my view, that is still a primary goal. We now know that, of course, also would have a huge prevention benefit. And a great example is prevention of mother-to-child transmission. The best thing is to treat all pregnant women, regardless of CD4, what's called Plan B, for their own well-being, and also because that reduces perinatal transmission and it virtually eliminates breastfeeding transmission as well.
And that's been an enormous success.
Huge.
Where it's been implemented properly.
Yep, that's right. And some very low-resource countries have embraced it because it's also so much simpler. CD4 levels and measurement is hugely complicated. Even a low-income country like Malawi has really led the way with universal treatment access for HIV-positive pregnant moms, and the benefits of that are just huge. So I think that's very fundamental. The second thing is that we have some new prevention tools like pre-exposure prophylaxis, where the trials just keep consistently showing that if people use these drugs, they work. So the question there is, who wants them? How are we going to do this?
How
are we going to pay for it? What's appropriate? But I think that this is potentially a very important new tool, and is going to be part, for some people, of the prevention mix. I think, for example, some particular key populations where the epidemic is still expanding, young gay men, young men who have sex with men. We are really not doing well with that population.
I think it's they don't see they haven't lived through the drama that you and I have in the early days.
Well, yes, I mean the individual level risks are important, but they don't explain it all. There are network level effects that are really important. The epidemic dynamic is different in epidemics among men who have sex with men. And we need to do a lot more on social structural level, and we need to do a lot better job with some of implementing and really trying to adapt some of the new prevention technologies. The individual level risks for these guys can be quite modest, and the likelihood of acquisition still very high. And that is also because basically prevalence drives incidence, and we are now at a place where the prevalence is so high in some communities that new young men coming into this community population, coming out, starting sexual life, are at just extraordinary risk. So we really need to implement some new tools and some new strategies.
Have you seen models that have been demonstration projects or whatever you want to call it that have been effective that maybe ought to be more lauded and repeated or replicated? Is there anything that,
Well, I think many people would point to San Francisco, where they made the very courageous decision, the policy decision, to offer treatment to all HIV-positive persons, irregardless of CD4 count. That's across the board, but of course, the majority of new infections in the U.S. are in young gay men, and of course, the majority of infections in San Francisco are in young gay men as well.
So if a person knows that they are going to be treated, and if they become positive, it makes a lot more sense for them to be tested more regularly.
That's right.
It's like test and treat or test and treat.
That's right.
Or whatever. Yeah.
That's right. And to start irregardless of CD4, and that's some of the best data at a population level that we have. That approach looks like it's beginning to reduce new infections, including new infections among men who have sex with men. So that's very encouraging. We have some other examples, the data from the UK that suggests that it's still not enough, and that there still are, unacceptably high rates of transmission, even when treatment coverage is very good. So this is a challenging area, and it's an unexpected one in some ways, because 10 years ago, we all thought that the hardest thing to do was going to be to turn around these high prevalence epidemics in sub-Saharan Africa. That's going very well.
Because they must feel really appreciative of the access that anyone gets. And I think for that reason, I think that may be the magic that happened there.
Well, certainly, the community mobilization, yes, is a big part of it. The government support is a big part of it. Putting the programs in place. But it turns out that if you do all of those things and you really get the treatment numbers up, you start to reduce new infections, and that a number of places have really started to turn that epidemic around. So that's just hugely encouraging. The challenge for the future is going to be that most of the world is not like that. HIV in most of the world is concentrated in key populations, in MSM, in drug users, in sex workers, transgender folks, people at very high risk who are socially ostracized and stigmatized. That's certainly the case across Southeast Asia. The heterosexual epidemics in this region, where we are at this conference, basically peaked in the 90s and have been in decline for more than a decade. Yet there is a great deal of unresolved work to be done for these socially marginalized folks and their communities, and that is critical undone work. The one region geographically where HIV is still expanding, Eastern Europe and Central Asia, that's the whole story.
It shows the worst example of how to not approach treatment.
That's right. And prevention, and dealing with the human rights issues, with the social and structural barriers, drug treatment.
Kept way below the radar, and I remember that was, I guess, the main reason the IAS meeting was in Vienna, because it was close to that.
That's right.
That block of countries
that was the
dealing
goal.
with the drama. So, where do you go next? What is apart from your taking on the auspicious position of the chair of the conference?
Well, so I think we have to work. There's an important research agenda about how to increase access for these marginalized populations. That's key. I think we need implementation science research around the use of the new prevention technologies, particularly for young gay men. And for drug users and sex workers, that's critical. I think pushing using this platform for advocacy around the social and structural changes that need to happen in so many countries is a big challenge, but it's work we have to do, because where HIV is still spreading, almost universally, we have social and structural problems that are aiding and abetting the virus, and not our response. So that's critical to work on. I think the new guidelines, in my view, are really a set of marching orders about getting the next half, the other folks who are not on therapy, who need to be, if they want to be, getting them access to care in an environment of diminishing resources.
So it's the next step after, I hate to keep on pushing the bar, but it seems as though that's the first thing out of anybody's mouth that was really a thinking person was, essentially the next level is going to be test and treat, or test and entry into care.
Yeah.
That's kind of what we've been talking about for a number of years, but I think the guidelines saying that, I think, will be a huge impact.
Yes.
So because that's what you said, that's basically what happens in San Francisco, and maybe it's the best route, Well, and it really is more affordable and that's the question I asked one of the panelists that Sunday it was how do we make this impact in a way that it shows that it really is the best way to go, despite the fact, the human issue. We're talking about this as a fiscal issue, and it may be the best fiscal solution.
Well, it turns out, first of all, of course, remember that once people are effectively treated, they continue to contribute to the economy of their countries, their families. That's huge. The issue of, for example, treating all pregnant women with HIV and putting them on therapy is also about preserving families and making sure that kids have parents. That's a huge economic benefit, and not doing it is a huge economic burden.
It's a double. It's a double
absolutely,
plus.
Absolutely. So we have some really important synergies. Happily.
Right. Well, your work's cut out for you.
Indeed.
And as it is for everyone's. I'm not putting it all on your shoulders.
Thank you.
But I appreciate you taking the time with us.
Well, thank you.
And I'm
always
looking
a pleasure,
forward to the next time, and maybe some even better reports.
Well, let us hope.
Okay. Thank you, Chris.
Excellent. Thank you.